try to make this talk as interesting as and interactive as possible. So feel free to interrupt me at any point and ask me any questions if you have. And I will also have some questions for the rest of you along the course of the talk. Yeah. Okay. So let's begin. So this is just the outline of our topic today on diabetes. First, I will go through with you on screening for diabetes, and then we'll talk about classification of diabetes and a short overview of pathophysiology of type 2 diabetes mellitus, and followed by complications of diabetes and an overview of treatment of the type 2 diabetes. And lastly, we will cover with the acute diabetes emergencies. And to go through these topics, we will go through a couple of case-by-case examples, yeah? Okay. So, so let's take this scenario. You just graduated med school, and while awaiting for your posting, you have applied for a temporary job at the health screening center, okay? And you have these three people coming to you who present to you, and you need to decide, now, who do you need to screen for diabetes? Okay, we have Mr. William, a 55-year-old bank officer who has no prior illness, but has been feeling quite tired lately. He feels thirsty a lot. He's lost some weight recently. His current BMI is 25 kilograms per meter square, and his blood pressure is 152 and over 94. And we have his wife, Mrs. Kate, a 52-year-old teacher who's been asymptomatic. Her own mother had diabetes, and she herself had a previous history of gestational diabetes mellitus during her last pregnancy 20 years ago, but has since repeated her OGTT after her pregnancy and was told to be normal. Her BMI is now at 22 kilograms per meter square, and the blood pressure is 120 over 60. Thirdly, we have George, a 24-year-old young web developer. He feels well, feels completely well. He's just your typical young guy in his 20s who leads a pretty much sedentary lifestyle. His mother, i.e. Kate, had a GDM, and he has always been told that he's been big boned since childhood. And his BMI is at 32 kilograms per meter square. And his blood pressure is 142 over 83. Okay, so who do we screen for diabetes? So basically, all of them needs to be screened for diabetes, yeah? Okay, because you see Mr. William here, he has symptoms of type 2 diabetes. He has osmotic symptoms, basically, and he's got some weight loss, okay? And he's middle-aged, and he's got some risk factors as well. Blood pressure is high, and he's even though he's lost some weight, he's still classified as overweight. And Kate, who has a background history of GDM and positive family history as well, so there's a risk factor there as well, even though she's appears to be lean and normotensive. And George here, even though he's young, but he leads a sedentary lifestyle and he has all the risk factors. He appears to be obese. He probably has some grade 2, grade 1 and grade 2 hypertension, and his BMI also is at the obese range. So now we proceeded to do random plasma glucose for these people. Yeah. Okay, now we have a 35-gram OGTT done for George. All right. So can anyone tell me who has diabetes? Okay, I'm going to call out names, yeah? Venjet, can you call out one name for me?
Okay, Mirza.
Yes, Mirza.
Good evening, doctor. Can you hear me?
Yes, Mirza, yes.
Yeah. So I think William and George both have diabetes, as William's resting plasma glucose is more than 11.1, and George's OGTT post 2 hours is also more than 11.1.
Yeah, okay, so it's a random plasma glucose, not a resting plasma glucose. Yes, a random plasma glucose of more than 11.1 automatically we can automatically diagnose a person with diabetes when he has a history of osmotic symptoms. Yeah, so you don't need to do a 75 gram OGTT for Mr. William. Okay, and Kate, her random plasma glucose only 6.5. She has some risk factors. However, she doesn't have any symptoms, so we don't need to proceed to do a 75 gram OGTT for her. And for George, even though he's young, but his random plasma glucose was 8.7, and so it was not normal at the random plasma glucose. So we proceeded to do a 75 gram OGTT, and his fasting is less than 7, but his 2 hours postprandial is more than 11.1. Okay, so William and George both have diabetes. So this is just an algorithm. This algorithm on screening and diagnosis of type 2 diabetes. Yeah. So this is for patients who are symptomatic. So we had Mr. William just now, who's symptomatic. Therefore, we just go for a venous plasma glucose at the random plasma glucose of more than 11.1. We can confidently diagnose him as type 2 diabetes. He did not need to go through another OGTT just to diagnose diabetes. Yeah, so he had symptoms of polyuria, polydipsia, fatigue, unexplained weight loss. Yeah, and in women they may have pruritus valvae, and men they may have balanitis, which he did not report. Nocturia is a very common complaint amongst men of middle age, which usually we may dismiss as prostatism, but we must always keep in mind diabetes as a potential diagnosis as well. Okay. And what about asymptomatic patients? Asymptomatic people who basically, it's a bit more complicated. We just need to remember if they have, because they're asymptomatic, we need to think of their risk factors. So these are just a host of risk factors that we need to consider. I may not go through every single one of this, but I'm sure you have read about it. So positive family history mainly, and amongst women, previous history of GDM. Yep. And any offspring of GDM women, all these are risk factors of diabetes. And if they have a BMI of more than 23 kg per meter square, or waist circumference of more than 80, and or for women, and more than 90 cm for men. Okay. And then you go ahead and do a random plasma glucose first. And if a random plasma glucose, again, if it's more than 11.1, you do not need to proceed with an OGTT. So if it's between 7.8 to 11, you go ahead and do an OGTT, and you have your readings of more than 11.1 and more than 7. Okay, that's your diagnosis of type 2 diabetes. So for your fasting, so between 6 to 7 is impaired fasting glucose, and for impaired glucose tolerance would be between 7.8 to 11 after 2 hours of a load of your glucose load. I hope I hope I'm not making it more confusing for you. Basically, I know it's very difficult at your stage to remember all these numbers. It gets easier as you practice every day and you look at the sugar numbers and get familiar with it. But how I just remember is basically 7 and 11.1. That's your magic number for your OGTT thresholds. Okay, and between that is 6 to 7 for your fasting, and 7.8 to 11 for your impact glucose tolerance. Yeah, so just these few numbers you need to memorize lah. More than 7, more than 11.1. Yeah. So now diabetes in Malaysia is very common. Currently, as of 2019, the prevalence of diabetes amongst adults more than 18 years old is standing at 18.3%, and is at an ever increasing rate. It's been increasing from 13.4% in 2014, and as much as 8.9% of people living with diabetes were undiagnosed. As of the latest National Health and Mobility Survey, or NHMS, in 2019, our Indian population take the largest cut of the pie at 31.4%, followed by Malays and Chinese. And there are increasing numbers of type 2 diabetics who are diagnosed very young, and they are very common among the obese. And why is it dangerous? Because in young patients who develop type 2 diabetes, they have a faster progression to nephropathy, neuropathy, and retinopathy, long-term complications of diabetes. And how do we classify diabetes? The talk today is mainly focused on type 2 diabetes, but as you all know, we have type 1 diabetes. The classical one would be your autoimmune mediated type 1 diabetes that commonly presents in the pediatric age group, and LADA, i.e. your latent autoimmune diabetes in adults. So this is the form of diabetes that presents later in life, but they phenotypically your type 1 diabetes, phenotypically are like your type 1 diabetics, like your children, but they are just present in adults. It's also an autoimmune mediated type 1. Therefore, these patients actually, they are insulin deficient, and they most likely, most of the time, they will have your antibodies, your anti-GAT antibodies, your anti-islet cells antibodies, yeah. And type 2 diabetes, as we all know, is characterized by insulin resistance as opposed to insulin deficiency, okay? But there may be some gray area in this. We'll go through this later on. And then you have your GDM among your pregnant mothers, and followed by your other causes, rarer causes of diabetes. Maybe not so rare, your drug-induced diabetes, i.e. Commonly your glucocorticoid induced diabetes is very common. And your endocrinopathy causing glucose intolerance, i.e. your Cushing's with cortisol excess. Acromegaly, growth hormone excess as well can trigger diabetes, okay, because acromegaly has your anti-insulinergic properties. And your exocrine pancreatic diseases such as cystic fibrosis and history of chronic pancreatitis. So basically, it is self-explanatory. Your pancreas basically, after a prolonged inflammation, your pancreas bursts out, your islet cells are no longer producing enough insulin. Therefore, you may develop hyperglycemia, okay? And a bit rarer, your monogenic diabetes, okay? Which the most severe kind of monogenic diabetes would usually present as neonatal diabetes. That's more of the realm of the pediatric endocrinologists. And MODY, i.e. your maturity onset diabetes of the young, it's a bit of a misnomer. So maturity onset diabetes of the young usually presents in a fairly younger age group, around your second to your third decade, sorry, in the 20s to your 30s, yeah. And you have very strong family history in families with MODY. Usually you will see your siblings or parents and or grandparents. Usually you need a 3 generation of positivity of diabetes, and usually amongst your first or second degree relatives as well, they will have diabetes. So you need to do genetic screening for you to diagnose this MODY. Why is it important to diagnose MODY? Because MODY generally responds very well to your sulfonylureas, okay? A lot of times we see patients who have undiagnosed MODY and they are treated with very high dose insulin, but they do not respond very well to it. Once you start them on sulfonylurea, they respond very well, and the insulin requirement may actually reduce significantly. Yeah. All right. Now, any questions so far about your classifications of diabetes? I forgot to mention your post-organ transplantation in diabetes. Yeah, so post-organ transplantation, why is it under drug-induced? It's because of your certain post-transplant immunosuppressive drugs that may actually trigger diabetes. Does anyone know of any examples? Anyone going to answer?
Hi, this is Quan. Can I answer?
Yep.
I think one of the example would be steroids, such as prednisolone.
Yeah, I already went through steroids, yeah. So,
Yep.
but true enough, okay, steroids is used as your transplant anti-rejection drug. Anything else?
Maybe azathioprine.
Azathioprine, no. Azathioprine doesn't really cause trigger diabetes, no. Anyone have seen renal transplant patients? Or even hematopoietic stem cell transplant patients? So your calcineurin inhibitors, yeah, okay. So typically your tacrolimus, yeah, they can cause high everything, yeah. They can have high K, high blood pressure, high glucose, yeah, okay. So that is a very common complication of your tacrolimus. That's why our nephrologists post-transplant, they monitor their FK levels, yeah. Okay, so it's important to keep an eye on these patients. Okay. They need these drugs, but these drugs also, it's like a double-edged sword. They come with their side effects as well. Okay. All right. So any questions about classifications of diabetes? If not, then we'll move along.
Can I ask a question?
Yes, go ahead.
Hello, I'm
May I know your name?
Yeah, just to ask, I'm Munhao from Manpao.
Okay.
Hello. Yeah,
Yep.
to ask the classification of the diabetes mellitus. Do we use the type 1, type 2, type 3, and type 4 now, or is it all one?
We don't really use type 3 or type 4, but we still do use type 1 and type 2 diabetes. But yes, you are right that there are newer classifications and newer ways to define diabetes. So we are thinking, the thinking is shifting towards your insulin deficient and versus insulin resistance in terms of your diabetes. But yes, in clinical practice, this type 1, type 2 diabetes, it's still very much in use.
Okay, thank you.
Yeah. Okay, so pathophysiology of type 2 diabetes. I'm sure everyone has gone through this in your preclinical years. So type 2 diabetes is a result of a combination of your insulin resistance in all your muscles, your fat cells, as well as your liver cells. Yeah. And it's also combined with the insulin secretory defect, okay, and resulting in increased gluconeogenesis. So it's a combination of multiple factors, including your certain genes that may predispose individuals towards developing diabetes, and certain adipokines, i.e. your hormones that are secreted by your fat cells, causing constant inflammation of your adipokines, release a lot of the cytokines, and constant hyperglycemia and free fatty acids exposure will lead to your beta cell dysfunction in your pancreas. And then because of that, your glucose, the glucose is constantly high, and it becomes a positive feedback cycle, and you will end up developing insulin resistance, and from there, type 2 diabetes will develop, yeah? So it's a combination, like I mentioned, it's a combination of multiple factors, including your genetic predisposition, will cause reduced beta cell differentiation and reduced beta cell function, and combined with environmental exposure of constant large meal size, poor meal timing, poor meal composition, as well as sedentary lifestyle and low activity and low glucose usage, will cause persistent hyperglycemia and hyperinsulinemia, which actually in the long run lead to insulin resistance. Stress as well will lead on to insulin resistance, And as your hyperinsulinemia as well will affect your adipocytes, will increase your adipocyte storage threshold and cause a release of free fatty acids in your from the ectopic lipids, causing a constant stress in your beta cells, and therefore leading you to develop impaired glucose tolerance. But you have to look here at the early stage of type 2 diabetes. You have to see that you actually observe that the insulin production actually initially increases during the early stages before you even reach your impaired glucose tolerance. Insulin production actually increases. Therefore, you have this phenomenon that patients who have like pre-diabetes may actually develop symptoms of paradoxical symptoms of hypoglycemia after a large meal because of they have beta cell hyperplasia at this stage, and actually they release a lot of insulin in response to a large meal. And then they develop paradoxical hypoglycemia even though they are not taking any medications here. And as time goes by, the insulin production in your beta cell actually reduces, and then your glucose levels continues to increase along with your insulin resistance levels, and hence you will reach a threshold where the insulin production cannot keep up with your insulin resistance. That is when type 2 diabetes actually develops. Yeah. Everyone understand? Okay, I'm going to move on. So moving back to our case, we have Mr. George, who is obese, and he was incidentally diagnosed with diabetes mellitus and at a routine general health screening. Now, what are the next investigations that we need to do? Can anyone answer?
HbA1c.
Okay, what else? What is HbA1c?
Glycated hemoglobin levels.
And what does that indicate?
Indicates the patient's blood glucose control over the past 3 months.
Okay, all right. What else? Okay, what other investigations through ESAND?
The renal function, liver function test.
Okay, very good. Renal function. Okay, what do you want to look for in renal function? So when you answer, when you answer your question, so every investigation that you do, you need to know what you want to look for and not just order, your standard full blood count, renal function, liver function. Everything needs to be, you need to have a purpose for every investigation, yeah? Okay.
Yeah, full blood count, renal function, liver function to check for any signs of diabetic nephropathy. Liver function to rule out other comorbid like liver disease.
What sort of liver disease?
Not very sure.
Okay, so he is obese, he has type 2 diabetes, high likelihood he may also have fatty liver disease, yeah? Okay, so fatty liver disease is very common among our young type 2s with obesity. Okay, anything else? Okay, let's move on, yeah? Okay, so we've sent full blood count, renal profile, HbA1c. We also need to do a urine assessment. Okay, you need to do a urine FEME and do a 24-hour urine protein as well as a lipid profile. Anyone care to interpret this panel of investigations? Ranjit, can you help moderate and ask for call out names?
Okay. Let's try from clinical students.
Yep.
Sherwin, do you want to try? Maybe starting with the renal profile.
Hi, doctor.
Hi.
Okay, so the is low. Sorry, it's within normal range.
What is low,
I
sorry?
think the normal range sodium is normal
Okay.
because the normal range is 135 to 145,
Okay.
and the potassium is normal as well.
Okay. Sorry, are you still talking or is your line breaking up?
Hello?
Yep, go
Hello,
on.
doctor, can you
Go
hear
on.
me?
Yeah, go on. I'm listening.
Yeah, sorry, because I lost connection for a while. Yeah, and the
Okay.
EGFR is low.
Okay.
I think it's stage 3A, 3A or stage 2. I forgot the values as well.
Okay. Go on,
Yep.
and then?
Case, then for FBC, the HB is at normal levels because the normal is more than 12.5. Then white blood cell is also within normal range because the normal is 4 to 11. Platelet is normal as well because the normal range is 150 to 400. I think the HbA1c for his age is slightly high because this HbA1c, if it's more than 8%, then it will be considered okay in elderly person.
Okay,
But
yes.
for
Good point.
his age, then yeah, so I think it's a bit high for his age.
Okay.
The normal value should be more than 6.5 roughly.
Okay.
6, if I'm not mistaken, yeah. For the lipid profile, sorry doctor, again, I really don't remember the normal values.
Okay, that's
so
fine.
I'm not too sure on this. Yeah.
Okay.
What
What else did I put there?
The urine volume 24 hour and urine protein.
What does that indicate?
I think there is some proteinuria.
Yeah, okay. So there is probably some microscopic, there's probably a micro albuminuria there, okay. So he's not hitting the range of your nephrotic range proteinuria yet, okay. What is the range of nephrotic range proteinuria?
Proteinuria, is it 3.5?
3 lah, so more than 3 will be your nephrotic range. 3 grams over 24 hours, okay. And why is that urine volume there?
To check whether he has polyuria or not.
No, not really. So it's basically to know whether you've collected a good sample of urine. Also, some patients who are already advanced chronic kidney disease, they may not produce a lot of urine, so they may actually produce just a little amount of urine. And yeah, like say if they only give you like 600 mils of urine over 24 hours, you may not be able to interpret the urine protein accurately. Yeah. Okay, so you're right. So basically, this gentleman, he's not anemic, so his HP is within a normal range. So for a young male, basically a male patient, the HP, male person, the HB should be more than 12. For a female, should be more than 11. Okay. White cell and platelet and are within normal range. Okay, sodium potassium isn't an issue. Okay, the urea creatinine is slightly raised. Sorry, I might need you to mute yourself, whoever is on. Okay, and the creatinine is raised. Okay, and this person has stage 3A chronic kidney disease, and he also has dyslipidemia. The total cholesterol is raised. your LDL is at 4.2, it's definitely high. So for a young person, we should target the LDL to be less than 2.6. And again, A1C is high risk. So we wouldn't say that 6.5% is normal range, but how we would phrase it is that we should have a target HbA1c, and you're correct. Target HbA1c for a young person of his age should be less than 6.5%. Okay, and the target the target HbA1c is a tailored target. Usually, it depends on your risk profile, your age, your comorbidities. If you are correct to say that an elderly patient with who is very frail, who is very prone to hypoglycemia, and who is very prone to risk of developing coronary events, we should definitely give a more lenient target of HbA1c of more than 8%, or of around 8%. That should be the target of HbA1c. But in a young patient who may stand to develop a lot of damage from chronic uncontrolled diabetes, you should be stricter with your control of your HbA1c. You should target at a lower of 6.5%. So other things that you need to check for the diabetic patient includes your ophthalmological screen. You need to screen for diabetic retinopathy, diabetic eye disease basically. So there can be diabetic retinopathy, maculopathy, as well as cataracts, and so on and so forth. You should do a baseline ECG as a heart screen. Okay, a lot of diabetics, they may have silent ischemic heart disease, or they may have silent arteriosclerosis that may be subclinical, but you may be able to pick it up on some ECG changes. All right, if you can pick it up early, you can send them off for a proper coronary angiogram or CT coronary angiogram, depending on their age or their risk factors. Also, you should assess their liver as well. I didn't have space here to put the liver function, but you're correct just now. It's important to check the liver function. You need to check for your alkaline phosphatase, whether it's raised together with your gamma GT. So these are raised in patients with fatty liver disease, okay, non-alcoholic fatty liver disease. And you also need to see the AST and ALT and your albumin as well. Okay, everyone clear? Any questions? No, then I'll move on, yeah? Okay, so moving on complications of diabetes. So there are a host of complications of diabetes. It can affect the whole body, but generally how we divide the complications of diabetes include your macrovascular complications and your microvascular complications. So your macrovascular complications, or we also call it your atherosclerotic cardiovascular disease, ASCVD, include your acute coronary syndrome, or your stable coronary artery disease, unstable angina, non-STEMI or STEMI, okay? And in your brain with larger vessels, you have strokes or your transient ischemic attack, and at your limbs, you may have peripheral vascular disease. Microvascular, moving on to the smaller vessels, you have your retinopathy, you have neuropathy, and neuropathy is also associated with your diabetic foot. So your diabetic foot is a combination of neuropathy as well as your peripheral vascular disease, yeah. And diabetic nephropathy is a very important complication to screen for in patients with diabetes. So other complications include recurrent infections in your genitalia, skin infections, cellulitis, or recurrent abscesses. Okay, and other eye diseases, like I mentioned just now, cataracts and glaucoma also is increased in patients with diabetes. And one condition that is less talked about is periodontitis, which is also much more common amongst patients with diabetes. And patients with diabetes, patients with periodontitis also have a higher predisposition of developing poorly controlled diabetes. And sexual dysfunction is something that is often overlooked. What are the common presentations of sexual dysfunction amongst patients with diabetes? Anyone has any idea?
Erectile dysfunction?
Yeah, so erectile dysfunction is very common. It's either from because of your peripheral vascular disease. It is a form of peripheral vascular disease where your blood supply is poor to the genitalia. Don't overlook this, because to some patients, especially young patients who have diabetes, this complication may be a very important factor that actually may significantly affect their quality of life. Okay. And in elderly patients, patients with diabetes have a higher propensity of developing dementia. Okay, so like we mentioned just now, HbA1c or glycated hemoglobin is a measure of your control of the diabetes over the past 3 months. So generally, it's because of your hemoglobin or in your red blood cells are constantly exposed to high levels of blood glucose, and they become glycated, and this is how we measure the average blood glucose control. And what are the common pitfalls of HbA1c assessment? Can anyone tell me?
It's not accurate if the patient has hemolytic anemia.
What else?
End-stage renal failure patient on the erythropoietin injection.
Yep. Okay, basically anything that will affect your hemoglobin should affect your HbA1c levels. Yeah, so anemic patients, patients with recent transfusion, patient on erythropoietin. So all of these patients, you may need to, you may have to take your HbA1c with a grain of salt. You might not trust it completely. Some of it can be falsely low, especially in anemic patients. So you always have to fall back on your glucose monitoring, okay, self-monitoring of blood glucose to actually determine whether this person's blood glucose control is adequate. Okay, another method of monitoring blood glucose that is recently developed over the past decade or so is your continuous glucose monitoring, or your CGM machines that can actually monitor the patient's second-to-second fluctuation of blood glucose levels. This is commonly used in patients who have difficulty with checking their blood glucose, or patients who we find to be very difficult to control their blood glucose with their insulin levels. And basically we get them in, we put them on a machine and patch, and that machine will actually detect the blood glucose for an entire week, and we get shown the machine, and at the end of it produces a nice graph that shows you a 24-hour blood glucose readings that will help you make clinical decisions to adjust the patient's treatment regime. Okay, so now moving on to treatment of type 2 diabetes. So remember that lifestyle and metformin remains the mainstay of treatment, but beyond that, usually now we are moving towards individualized treatment regime depending on patient's profile. But never forget that lifestyle modification, i.e. your strict diet control and exercise, are very, very important in your diabetic patients. And metformin has very strong evidence dating back to the early 2000s with your UK PDS trials before. So they have shown that metformin actually gives significant cardiovascular benefits, and therefore it should be the first line of treatment of type 2 diabetes. And moving beyond that, if your HbA1c is not individualized to target, like I mentioned just now, your targets should be individualized according to patient profile and risk factor, and then you need to consider their patient profile. So we have people depending on whether they are overweight or obese, or they have normal weight, or they have increased risk of hypoglycemia, especially amongst the elderly or patients with chronic kidney disease, patients with very bad diabetic kidney disease, high risk cardiovascular disease, atherosclerotic cardiovascular disease, and heart failure. So how did all of these regimes come about? All these were derived from multiple your cardiovascular outcome trials amongst different patient profiles, as well as how these drugs work itself. Yeah. So amongst patients who are obese or overweight, generally we will prioritize them with a GLP-1 receptor agonist, or your SGLT2, sodium glucose cotransporter inhibitor, SGLT2 inhibitors such as your empagliflozin, dapagliflozin, and all this, they have been clinically proven to actually induce weight loss and improve diabetes control. And amongst patients who have increased risk of hypoglycemia, DPP4, so we need to avoid basically all the drugs that can cause hypoglycemia. So generally, this would be our elderly, frail patients who are prone to falls, who don't have anyone at home monitoring them. You really want to steer away from drugs that can cause hypoglycemia, such as which drugs can cause hypoglycemia?
Sulfonylurea?
Yep, so sulfonylurea, you generally want to steer clear away from sulfonylurea amongst your elderly patients. So very common drug that causes a lot of issues with elderlies is your glibenclamide. Okay, it is still, even though we are trying to steer away from it, it is still used quite a lot in the community. So you need to watch out for it. So patients who are entering the geriatric age group, even though they have been on glibenclamide for 20-30 years, you may need to advise them to stop the medication as their risk of hypoglycemia increases. So as you can see, the sulfonylurea still is within this regimen of this patient profile, but it's way low down there, okay, and it's usually we use the safer second generation sulfonylureas such as your gliclazide, yeah, that has much lesser risk of hypoglycemia. Okay, and patients with kidney disease, so this is moving towards the realm of your renal outcome trials. Okay, you have your trials that have shown that this SGLT2 medications actually improve, not really improve, but actually retard the progression of chronic kidney disease among diabetes patients. Okay, and GLP-1 receptor analogs, also your liraglutides or whatnot. So all these also, they have evidence in kidney disease patients. And DPP4, GLP-1 has actually also good evidence in retarding CKD progression. DPP4 is a kidney neutral drug. So your DPP4 inhibitor medications such as your linagliptin, sitagliptin, so all these are renal neutral drugs. So it neither protects the kidney nor does it worsen it, but it is not renally excreted, so you can use it even in advanced chronic kidney disease. Sulfonylurea, you can still use it, but it's not advisable in your advanced CKD patient. And cardiovascular diseases, your GLP-1 or your SGLT2, so these have very strong cardiovascular outcome evidence. So therefore, they're higher up. And the heart failure, your SGLT2 patient, your SGLT2 drugs have the best data in heart failure, therefore they're high up there. As you can see, we generally try to save your insulin way down until the patients have failed all other options of either your oral or your weekly injection drugs. Your GLP-1, either your weekly or sometimes a daily injection. So Mainly because insulin also, it's a double-edged sword. It can help control your blood glucose, but it also can cause hypoglycemia. So, and also a lot of patients will be very averse to injecting themselves multiple times a day. So we try to hold on to insulin initiation until they have exhausted all other options. Okay, so for our patient here, Mr. George, who he's overweight and obese. So generally, we want to go through this algorithm. And so now, moving forward, so 6 years later, you are now a medical registrar. You're on call in emergency department. And you see Mr. George again. He is now 30 years old, and he's been living with type 2 diabetes for the past 6 years. And he's also at hypertension. He also hypertensive, like we saw just now, and he also has dyslipidemia. And now he presents to us, to the emergency department, with a complaint of fever, vomiting, and lethargy for 3 days. So just a crude physical examination. You were told by the referring emergency physician that he has dry mucous membranes. His blood pressure was 102/75. His pulse rate is 105 beats per minute. His temperature is 38.4 degrees Celsius, and his respiratory rate is 24 per minute. Anyone wants to comment on this? And Jack, can you point someone out? Is Jingyi here?
Jing. Hold on. Let me check the name first. Yes, Lao Jingyi. Are you here with us, Lao Jingyi?
Okay, maybe call someone else.
Okay, I'll start from the top.
A clinical student.
Aida Shahira. No response as well. Second on the list, Ayun. 0321 Ayun. How about Bill?
So is anyone still actually listening?
Participants dropped quite a bit when we started.
This is Mirza. Is it okay if I try again?
Yeah, go ahead, Mirza.
Okay, so the question was to interpret this clinical picture, is it?
Yep.
So George with underlying type 2 hypertension dyslipidemia. From the brief history, it sounds like he could be in an acute diabetic emergency. On physical examination, it looks like he's dehydrated. The blood pressure is slightly hypertensive, but not truly in shock level, 90/60. Pulse rate is tachycardic, so he's also febrile. His respiration is also, he's tachypneic. I would say he's dehydrated in compensated shock, possibly due to HHS.
Yeah. Okay. He may have a multifactorial shock ongoing. He may be hypovolemic, probably also septic. Yeah. Okay. But he's not in full-blown septic shock. You're correct to say that his blood pressure is borderline. He was known to be hypertensive before this. You know, his baseline blood pressure before this was 140 plus over 90. It may be even higher now, his baseline blood pressure. But now he presents to you with a blood pressure of 102/75, probably lower than his baseline. And he's compensating by having tachycardia on top of fever. And his respiratory rate of 24 per minute is not normal. He's probably tachypneic. You need to rule out some underlying respiratory condition, or it also could be a acidotic breathing. Yeah. Okay. Now, any further history you want to ask?
I think I'd like to ask a bit more about his diabetic control to see was he previously changed to insulin, and what's the compliance recently, and any recent infection or anything that could have triggered the HHS.
Yep. Okay. All right. So you're correct. We need to identify any precipitating events. Okay. So he told you that he has fever since 3 days ago. He has been having loose stools, increasing in frequency, and has been vomiting food particles for the past 1 day. His appetite has been really poor, and he's been skipping his insulin because of his appetite that is poor. And his cough, he has no cough, no runny nose, no shortness of breath, no abdominal pain, and no chest pain. Just as a standard screening, we'll also be asking him whether he's got any COVID-19 contact, so he doesn't have any. And yes, you're correct. We need to know of his control of diabetes. He tells you that his last HbA1c 6 months ago was 9.8%. And in the interim from the last time when you saw him, he has required laser phototherapy. And he was told by his doctor that his kidney function was not normal. He's got some feet numbness, but he has no history of angina nor any previous diagnosis of ischemic heart disease. And his New York Heart Association classification of heart failure is at NYHA1. So his medications at baseline include subcut atropine 24 units TDS, Insulatard 30 units on night, metformin 1 gram BD, atorvastatin, as well as a perindopril pill. Okay, so full physical examination was done. His vital signs were as previous. Currently, his body weight is 74 kgs. He has lost some weight from the last time when you saw him. His tongue is coated. His lungs are clear. His abdomen is soft, but there's some tenderness over the epigastrium. The cardiovascular system was normal. The lower limbs, he had some diabetic dermopathy, but there were no open wounds, no swelling, tenderness, and there were no edema. What other examination do you want to do? Anyone?
Neurological examination, check for the sensory loss, and also fundoscopy.
Okay, so those are important, but not so much in an acute situation. So now we think that he's got fever, he looks like he's got some infection, but based on the examination you've done so far, you haven't identified any particular source of infection yet. Yeah, those that you mentioned are more like your long-term complications. So he already told you that he's got some eye disease. He's probably got some diabetic retinopathy before because he needed laser phototherapy. So you can do a fundoscopy, but it's not the most important thing to do right now. Okay. The numbness is there. He already told you, you think he probably has it. You can check it, but will that affect your current management? So probably not. So other physical examination is important. So we checked his perineal examination, and then you found that he has erythematous, tender, boggy swelling at the perianal region. So basically, I just want to highlight here that never forget to do a full physical examination for your patients with diabetes that present with acute diabetes emergencies. So they may not tell you either because it doesn't bother them that they had this pain over the perianal region, or they're too shy to talk about it. But if you don't take the effort to actually examine the perineal region, you can actually miss the source of infection that had triggered his current diabetes emergency. Moving on, we did some investigations. Okay, anyone would like to comment on the current blood investigations? Anyone?
Perhaps Carol would like to try.
Hello, doctor.
Yep.
Yeah. So based on the investigation result, from the full blood count, I can see that the patient has a red white cell count mainly neutrophil predominant. And then for the renal profile, patient has raised urea and creatinine because I think the patient is dehydrated. And then the glucose result is patient is hyperglycemic, and also patient might have a ketonemic, slightly raised keton. For the ABG, the patient has a low pH, and then with a raised serum lactate. And low CO2. So I think that it's a metabolic acidosis with some compensation through respiratory. And then for the urine FME, there's definitely glucose and also ketone presence in the urine.
Okay, so can you tie it all up together?
Yeah, so the patient is currently in a diabetic ketoacidosis with uncompensated metabolic acidosis, I think.
Okay.
Most likely secondary to infection.
Very good. Okay. Okay, so you also mentioned he probably has acute kidney injury as well, yeah? Okay, so this is your chest X-ray, which was normal. Your his ECG was done. He has sinus tachycardia. Ultrasound of perineum was done. So there's a perianal collection measuring 5.5 centimeters, and you also would run a blood culture because he presents with sepsis, and a blood culture actually grew gram-negative bacilli. Okay. So now, what's our diagnosis? Diagnosis is patient probably has a gram-negative bacilli sepsis secondary to perianal abscess, complicated with diabetic ketoacidosis, acute kidney injury, and pseudo-hyponatremia. So as you can see, his sodium here is 128, okay, but his blood glucose is actually high. So this sodium likely is not truly low. So you will need to correct the glucose to the sodium. Yeah. We'll talk about the pseudohyponatremia in hyperglycemia shortly. Okay. So just briefly about pathophysiology of DKA and HHS. So understand that DKA and HHS is a spectrum of presentation involving hyperglycemia and dehydration. So this is present in both DKA and HHS, as well as electrolyte disturbances with excess ketone body production and metabolic acidosis. And this is typically triggered by a stressor such as infection, stroke, myocardial infarction, in a state of either absolute or relative insulin deficiency. So it's like I mentioned, it's a spectrum of disease. So at one end of the spectrum, this is your patients who are more like your type 2 diabetics who have been chronically insulin resistant. They still have some insulin production from their pancreas. So therefore, we call it as a relative insulin deficiency. And therefore, because there's still some insulin, probably there is absent or some or minimal ketogenesis. So ketoacidosis is not so predominant in this end of your diabetic emergency, but generally they lose more fluid from their body and they are more hyperosmolar. Therefore, we coin this end of the spectrum of patients as who present with this as a hyperglycemic hyperosmolar state. And on the other end of the spectrum is patients with absolute insulin deficiency. So patients whose beta cells aren't producing any insulin at all, therefore driving them into a ketoacidotic state. And all this will actually trigger them to tip them off into a positive feedback cycle, basically, and then they will go into a acidosis and they develop diabetic ketoacidosis. So your immediate management for the patient, you started the patient on IV fluid, you started the patient with boluses of normal saline running at 500 mils over 50 minutes, and then you give him 1 liter of normal saline over 1 hour, and then 1 liter over 2 hours, over 4 hours, and 6 hours. Okay, so remember that patients with DKA have absolute fluid deficit of around 6 to 9 liters, yeah, and HHS patients may have a higher fluid deficiency, may go up to 9 to 12 liters. Therefore, you need to replace a lot of fluid to these patients, yeah. And at the same time, in a separate line, you would start the patient on a maintenance drip, running at 3 liters over 24 hours. And in this maintenance line, you will give the patient some dextrose if needed, or if not, you will give the patient some saline, just normal saline with potassium chloride. You will start the patient on IVI insulin, 7 units per hour. Okay, so in patients with DKA, so they are insulin deficient. Therefore, they need a higher rate of insulin infusion. The rate of infusion of insulin is usually 0.1 units per kg. So his body weight was 72 kg. Therefore, you're starting on IVI insulin at 7 units per kg. So if it's a patient with HHS, the insulin rate will be slightly lower, running at 0.05 units per kg, because they actually do not need that much insulin, but what they really need instead is the fluid boluses. So you will also start the patient on antibiotics for the infection. You chose Unicin because it has good gram-negative coverage for a perianal infection. And you referred the surgical team for source control. It's very important. So an abscess sitting there, you need to drain it. And never ever forget that patients who present with DKA or HHS are actually very pro-thrombotic. So meaning because they are very dehydrated, they have a very high risk of developing your thromboembolic disease, such as your deep venous thrombosis and your pulmonary embolism. So you started the patient on subcut enoxaparin 40 mg OD as a thromboprophylaxis. And 6 hours later, so this is his current blood profile. And what has happened? Can anyone care to elaborate?
Divya, would you like to try? Pham Zi Kiong.
Okay, so from the renal profile, it seems to be normalizing. The sodium is back towards the lower limit of the normal range. And the urea is also improving, however, it's still slightly higher. The creatinine as well. And from the ABG, the patient is still acidotic, but not as severe as the previous blood results. Yeah.
Anything else?
Not that I can appreciate.
Okay, so you see the ketosis is still there. The patient is still ketotic, still acidotic. The blood glucose is actually still on the high side, yeah? So it's inadequate improvement in the ketoacidosis. So what would you do at this point? Okay, so step number one, you need to make sure that you need to check the IV infusions, whether your IV drip and your IVI insulin is actually ongoing, yeah. If not, there's actually no point that whatever you're asking the nurses to do. Okay, so if you're sure the infusion drips are going in correctly, then you need to increase the IBI insulin by at least 1 unit per hour, and then reassess later. So now 18 hours later, so this is the current blood profile. Anyone want to comment?
Ruben?
Yep. For the renal profile wise, we see a drop in potassium, which should be, maybe you can supplement more potassium in the next type of management. And also anion gap wise is normal. Urea and creatinine is still high. APG wise is getting better lah. However, I think it's still inadequate.
Okay. So why is he still acidotic? The ketone is already improved to 0.1 already.
Probably you have to identify other causes of metabolic acidosis.
Okay, yes, very good. Yeah, what other causes that can you think of in this situation?
Since it's a normal anion gap metabolic acidosis.
Very good, yes.
Actually, I'm not too sure.
Okay, all right. So anything that you see here is what are your causes of normal anion gap metabolic acidosis? Do you remember?
No, I only remember the high ion gap.
All right. So if I'm not mistaken, the normal anion gap is your HADAPS, yeah? So hyperchloremia, okay? So he's actually developed persistent metabolic acidosis due to hyperchloremic normal anion gap metabolic acidosis. You can see his chloride has actually risen because you've been giving him a lot of normal saline. Yeah, his sodium also has gone up to the higher end of normal. His chloride is beyond the normal range. Okay, his anion gap is within normal range. Within a normal anion gap range. Lactate is no longer an issue. Ketone is no longer an issue. So it's just the chloride causing a resistant metabolic acidosis, yeah, normal anion gap metabolic acidosis. So the management is to switch the maintenance drip to a lower saline content drip, so like a 0.45% rather than a normal saline 0.9%. Okay. So a quick run through of management of DKA. Step number 1, you need to be able to identify and recognize the DKA. So with a blood glucose of more than 11, ketones of more than 3, and acidosis of pH less than 3 or bicarb less than 15. And a marker of severity of DKA is when your ketones are more than 6, pH is very low, less than 7.1, and a bicarb of less than 5. So single digit bicarb usually is not a good sign, yeah? So the outline of your management of DKA, these are your usual go-to principles, yeah, of management of DKA. Step number 1, rehydration. Like I mentioned just now, these people are all very dehydrated. Step number 2, you need to make sure that you get an insulin infusion as soon as possible, and need to maintain electrolyte balance, because if you're giving insulin, you may drive down their potassium. And you always need to remember to treat the precipitating cause, be it an infection, a myocardial infarction, a stroke, or whatnot. And never forget thromboprophylaxis if there is no contraindication. So generally, as a patient comes to you in emergency with DKA, you need to set 3 large bore IV lines to give all these infusions that you're giving: hydration, insulin, antibiotics. Yeah. And one line for bolus, okay, one line for your maintenance strips that you would run concurrently with your bolus. Yeah, so within that maintenance fluid is where you will give any potassium replacement if needed. Okay, if your potassium is dropping to less than 3.5, you need to up the potassium to 1.5 grams per pint. Okay, so all these you will learn as you are doing as you're managing patient later on actively in the ward. And another separate line for your IVI insulin. Okay, usually we continue the IVI insulin until the ketoacidosis resolves, yeah, and the definition of resolution is usually less than 0.6 of ketones, yeah. So your targets of treatment in DKA are your reduction in your capillary blood glucose of 3 millimoles per liter per hour, blood ketones reduction by 0.5 millimoles per liter per hour, and bicarb to increase by 3 millimoles per liter per hour, and maintain your potassium within a normal range of 4 to 5. So the magic number to remember in your DKA management target of treatment is 3.53, yeah. So you target to replace the absolute fluid deficit to 6 to 9 liters within the first 24 to 48 hours. Okay, if your rates are not achieved, means your targets are not achieved, you need to review your hydration rate and the insulin infusion rate, meaning that you need to, number one, make sure that the pumps or the lines are working. And if the glucose is not improving, ketosis is not improving, you should increase your insulin infusion rate. And if the glucose drops too rapidly, you may need to reduce your infusion rate. Yeah. And if the glucose drops too fast, but you still need the insulin to drive down the ketosis, you can consider to add on some dextrose in their drips. Okay. So you need to monitor their blood glucose hourly. You need to monitor their venous blood gases. Okay, and the renal function 4 to 6 hourly to make sure your sodium and potassium are within normal range. Ketones 3 to 4 hourly. Optimally, yeah. Okay, this depends on your setting. Some if you're staying in a if you're working in a more rural setting, you may not have the benefit of checking your serum ketone regularly. You should check the oximetry, and also you should always monitor their urine output to aim at 0.5 mils per kg per hour. Yeah. And this is just a regime of potassium to add in each 500 mils of normal saline if needed. So I'm not going to go through this. So just basically running through 60 minutes after the first hour to the 6th hour, you should complete your boluses and continue your maintenance fluid. But always remember, in your elderly, pregnant, or your heart or renal failure patient, you may need to be more cautious in your fluid resuscitation. Therefore, you should always monitor the IO chart strictly. And never forget, like I mentioned just now, precipitating event, thromboprophylaxis, and managing, and also monitoring your ECG, especially if they have hypo or hyperkalemia. So ideally, you should target for your DKA to resolve within the first 6 to 24 hours, yeah. And beyond that, after you have resolved the ketoacidosis, you can switch the insulin rate infusion to a variable rate. And resolution of the DKA is defined by pH of more than 7.3, bicarb of more than 15, and ketone of less than 0.6. Okay, and moving on to HHS, like I mentioned just now, it's common in type 2 diabetes, and the marker of HHS is severe dehydration and marked hyperglycemia. Usually their blood glucose is much higher than patients who present with DKA, because they are insulin resistant, and their serum osmolarity is also high at 320. And basically, how you measure the effective serum osmolarity is by 2 times sodium plus potassium plus glucose. And like I mentioned just now, pseudo-hyponatremia, so when the patients come with very high blood glucose, their sodium may be falsely low. So this is your formula to correct for corrected sodium. basically you take a measured serum sodium. So for our patient just now, his serum sodium was 128. Okay, that was measured from the lab, yeah, and his blood glucose on presentation was 28, yeah. So you take the measured blood glucose 28 minus 5.6, okay, it will and then after you divide by 5.6, so 28 minus 5.6 is around 22, so divided by 5.6 is around 4, so 4 times 1.6 is around 5, so it is 128 plus that 5, so you get a ballpark of around 134, 35 of his sodium, so you know that his true sodium isn't actually that low. Yeah. Any questions so far? So if no questions, I'll move on to management of HHS. Very similar to management of DKA. It's just that you need to remember that HHS, their fluid deficit is higher compared to patients with DKA. Their fluid deficit is around 9 to 12 liters. And fluid replacement, usually just by fluid replacement with normal saline itself, may actually reduce the blood glucose rapidly without even giving much insulin. Yeah, but similar to DKA, you need to set 3 lines to run some fluid boluses and starting maintenance rate similar to DKA. And you need to start the insulin infusion rate at a lower rate, like I mentioned just now, 0.05 units per kg per hour. And the aim is to reduce your blood glucose by 4 to 6 millimoles per every hour, and serum osmol to reduce by 3 to 8 millimoles per hour, and also never forget thromboprophylaxis. Okay, now moving next to your patient, moving on, his DKA has now resolved. His ketone is less than 0.6 times 3. You manage to bring him out of DKA. The bicarb is improved back to normal at 24. pH is now 7.4. You switched his variable rate insulin infusion, and his glucose improved to 7 to 10 overnight. And now you calculated that overnight in total he had required 60 units of insulin, and he started to take orally. He stopped vomiting, and our surgical colleagues have managed to do drainage of the perineal abscess. And then what's next? We may need to start planning for his insulin regime. Okay, so now you want to take him off insulin infusion. You want to overlap him to subcutaneous insulin. So once a patient, so if there are any house officers amongst you, so this will be very useful for you of how you want to plan to overlap patient from IV to subcutaneous insulin. Once you're able to take orally, you need to decide from their previous stable, whether they have a previous stable dose of insulin, then you may consider restarting an old dose. Or if they are unsure of their dose, or their dose is unstable, their blood glucose was uncontrolled from their previous dose, then you may use this formula whereby you use the total daily dose of insulin, and you can calculate from a total daily requirement on your IBI like our patient just now. Or you can estimate it by 0.5 to 0.7 units per kg per day. And maybe this may be lower in elderly renal failure patient or patients with risk of hypoglycemia. So once you have the total daily dose, you split it into 50% into your basal, and then 50% into your prandial, and then take the prandial and divide it into your 3 main meals. So once you give the prandial, you can prandial subcut extrapate. You can stop the infusion 30 to 60 minutes later, and then you need to make sure that the basal insulin also started as well. So, for example, in our patient just now, like I mentioned, he had IVI insulin, and you calculated from the IVI insulin, he had a total daily requirement of insulin of 60 units. So you split it into 50% basal and 50% prandial. Yeah. Okay. So basal meaning your insulatard, you give it either 30 units on night or you can give him 15 units twice a day, either 10 o'clock in the morning, 10 o'clock at night, twice a day. And your prandial, you take the 50% of the 60 unit will be 30 units, and you divide it into 3 meals of 10 units 3 times a day, your pre-breakfast, pre-lunch, and pre-dinner. So for those of you who are not familiar with your types of insulin, just remember that how we play around with our doses of insulin and our types of insulin. First, step number one, you need to know your insulin and know their duration of action as well as their onset of action. Yeah. And therefore, once you know that, you can use that insulin to tailor the therapy to mimic your normal physiological insulin secretory patterns. So normal, as you can see in this graphic over here, the gray silhouette at the back will show you normal physiological spurts of your insulin doses, insulin levels in your body throughout the day. There is always a background basal, what we call the basal insulin concentration in your body, as well as spikes of insulin during each meal intake. So to maintain a basal insulin, usually we need to use either a long-acting insulin or an intermediate-acting insulin. Yeah, so your long-acting insulin are your insulin analogs, such as your Lantus, Toujeo, Levemir. So these have a much flatter curve of action. As you can see, that their duration of action is about 24 hours, and it takes a longer time for them for the onset to set in. Whereas for insulatard, which is very commonly used, the duration of action is around 10 to 16 hours, and the onset of action is 0.5 to half an hour to 1 hour. And for your prandial insulin, commonly used is your Actrapid. So your Actrapid, the onset is around 30 minutes. That's why we always ask the patients to inject it 20 to 30 minutes before their meals. And the duration of action will last for up to 6 hours. Whereas the newer generation of insulin analogs, such as your Novorapid and Humalog, they are your rapid-acting insulin, have a much faster onset. So these patients who are using Novorapid or Humalog, they can actually inject the insulin immediately right before their meals. And usually the duration of action is slightly shorter than your short-acting insulin. Yeah. And again, you have your pre-mixed type of insulin, and this is just basically a combination of your rapid-acting and your long-acting, or your short with the intermediate-acting. Yeah. And this is preferred for patients who do not want as many injections per day, either because of their busy schedule, or usually it's their busy schedules. They don't like to inject so many times. They are afraid of needle injections or whatnot. Yeah. Any questions about insulin so far? Okay, if no questions, I'll move on. So next morning, you found your patient that you were informed by the staff nurse he was found to be unresponsive. His GCS was E3, V4, M5, okay, and his capillary blood glucose was 2.2. Anyone want to comment on this?
How about Divya?
So patient appears to be unconscious, and the blood glucose shows that he's hypoglycemic. So you should give him glucose, but since he's unconscious, you should give dextrose 50% IV. Yep.
Okay. So managing hypoglycemia, how do you manage hypoglycemia? Step number one, you need to define hypoglycemia. So anybody knows any widely accepted definition of hypoglycemia?
Blood glucose level of less than 3.9.
Okay, in a diabetic patient, you usually say anything less than 3, non-diabetic, diabetic patient less than 4, a non-diabetic patient less than 3.5. What I'm looking for is a criteria, yeah? So a common, usually for us to say that this is a true hypoglycemia, patient needs to fulfill what we call the Whipple's Triad. So apart from a low blood glucose reading, so they should also have signs and symptoms of hypoglycemia, as well as a documented resolution of the symptoms with a restoration of normal blood glucose. So if you fulfill all three, and then you know it's a true hypoglycemia. So if patient is alert and able to take orally, you can always give them something sweet to take. Okay, so it's either a sugary drink or 50 grams of glucose, and then recheck the blood glucose 10 to 15 minutes later, and then repeat your blood glucose and check it repeatedly until you reach a target of 4.0. If it's still low, give them another one, yeah. And then if it's already near their meal time, once they achieve a normal blood glucose level, you can still give them a half dose of their prandial insulin, and then ask them to take their normal meals, either rice, bread, or whatnot. Yeah, so they still need that that insulin. Don't rush off and straight away withhold the insulin if they're going to eat, because otherwise the blood glucose will go back to will shoot high up again. If a patient is reduced level of consciousness, like you correctly mentioned just now, you need to give them IV glucose via dextrose 50%, 20 to 40 mils, and then repeat your capillary blood glucose, and then manage accordingly as above. So in general, if a patient is taking any oral antidiabetic agents, such as the sulfonylureas, you need to withhold that, or you need to consider reducing your insulin dose. And you may need to investigate for causes of hypoglycemia if they are not taking any oral antidiabetic agents, such as the liver or renal failure, or if rarer causes of endogenous production of insulin, such as insulinoma, or your IGF-2 secreting tumor. Okay, and and also never forgetting your common causes of hypoglycemia, i.e. your oral antidiabetic drugs. So sulfonylurea, such as your glucoside and glibenclamide, and medications that don't cause hypoglycemia, metformin, your DPP4 inhibitors such as linagliptin, sitagliptin, your SGLT2 inhibitors such as empagliflozin, dapagliflozin, etc., and carbos as well does not cause hypoglycemia. Okay, so now summarizing everything, take-home messages. If you forget anything, you forget everything, so just don't forget that diabetes is very common, and the complications are very numerous and devastating. And especially amongst diabetes in the young, early detection and treatment is essential. Okay, now anyone has any questions?
If you have any questions, you can unmute your mic and speak it out, or you can type in chat and I'll read it out to doctor. We can have 15 minutes for question and answer session.
Okay. Anyone wants to ask? We can go back to the slides. We can go through anything that you're unclear.
if there are no questions within the next 2 minutes, we will end the session.
Good evening, Dr. Lim. This is Mirza.
Yep, hi Mirza.
I have a question regarding the classifications earlier for like the other types of diabetes. Would the management be similar? Like, of course, you would treat the underlying cause for the secondary diabetes, but are there like cases where we have to change the like type of insulin or the oral antidiabetic? Like, is there anything special we need to note of the management?
Yeah, so like I mentioned just now, okay, definitely your type 1 diabetes, you should not give them any medications that can trigger diabetic ketoacidosis. A more common one, such as your SGLT2 inhibitors, definitely is contraindicated in your type 1 diabetics. Okay, and your basically the regimens I explained to you just now are more for your type 2 diabetics. And your type 1 diabetics definitely will need insulin rather than oral therapy. But having said that, patients with type 1 diabetes who have been living with diabetes for many years and develop complications and they of chronic hyperglycemia and hyperinsulinemia, so they also may actually become insulin resistant. And as they grow older, they may gain weight, they may become overweight or obese, and they may also benefit from your typical type 2 diabetic drugs such as your metformin to increase their insulin sensitivity as well. So definitely your metformin is not exclusive to your type 2 diabetes patients only. And like I mentioned just now, MODY, maturity onset diabetes of the young, will definitely benefit from sulfonylureas, okay? And the other types of your other causes of your diabetes. So all this depends on the underlying pathophysiology of what has caused the hyperglycemia. So, for example, you know that pancreatitis patients, pancreatitis-induced diabetes means that this patient is actually insulin deficient because the pancreas is not able to produce insulin. Therefore, the therapy would veer towards starting the patient on IV subcut insulin rather than oral therapy, yeah, or drug-induced hyperglycemia, such as glucocorticoid-induced hyperglycemia. You may want to consider reducing their steroid dose as much as you can, whether if they need or do not need it, yeah. And then, for example, your Cushing's as well. Okay, if they have Cushing's, then the treatment of the underlying Cushing's disease by removing the tumor will actually help to control your diabetes. Yeah, Cushing's or acromegaly. So that's why it's very important to understand the pathophysiology behind the type of diabetes that your patient has to tailor your treatment accordingly.
All right, thank you, doctor.
Yep. Any other questions? How many of y'all are here?
Currently 49 people, including the two of us.
Oh, okay. Very good. Is everyone from UM, or I heard just now you mentioned there's someone from another university, right? All of you students, any of you are house officers or medical officers even?
I think most of us are students, Dr. Lim. There are some students from Manipal and UMS, I believe, in the chat room also, since we opened it to other medical schools too. Yeah.
Okay, cool. Have you found this useful?
Yeah, I personally found this session tonight very useful, especially seeing it going through cases. And, like, the management part was really terrific, and like, it was a good recap also at the start. So thank you so much, Doctor.
Sure. So I'm just a bit worried that your preclinical students may feel a bit left out. Therefore, I did try to go through some of your basic pathophysiology of diabetes, but just understand that that part also can be, it's actually very complicated, and there are a lot of studies ongoing still on how exactly diabetes develop at the molecular level. So that part may be a bit dry. But if you're in the clinical years, you may find that actually managing diabetes is actually quite exciting, because over the years we've had many new classes of drugs, and we have much more options of treating diabetes now as compared to when I was a student. So previously it used to be just metformin, insulin, but now we have so many new types of therapy that may be able to help different types of patients.
Hi, Doctor. Good evening. Thank you for your presentation. So I'm wondering if whether or not the compensation of metabolic acidosis, whether or not is it clinically significant, whether it is compensated or not compensated.
Whether is it significant? Yes, it's important that compensation is important of your metabolic acidosis, because once you are decompensated, that is when you run into trouble. Yeah, because basically at the cellular level, if you are acidotic, your cells will not function properly, and the most important cells in your body which you're worried about is your heart, your myos, your basically your heart cells lah, yeah. They may not contract properly in an acidotic state lah. So you really want to avoid your patient from going to severe metabolic acidosis to prevent cardiogenic shock and death lah. Okay, basically acidosis is not severe, metabolic acidosis is not compatible with life, basically. So I will not go through the whole compensation of metabolic versus respiratory. That will take another hour to discuss about. Yeah, but definitely we always aim to normalize any acidosis. Therefore, your body is always trying to compensate one way or another if you have developed either respiratory or metabolic acidosis.
Okay, thank you for the answer. And also another question is there a quick way to know whether or not the patient is compensated if we don't use the calculation?
You mean your Winter's formula and all that, is it?
Yes.
Yeah, personally, I don't use Winter's formula. The quick way I just look at the pH and the bicarb. Either so number one, you look at the pH, whether it's within your normal range of 7.35 and 7.45. If it's below, it's beyond that level, you know in general that it's actually decompensated already. Okay, and then you look at the bicarb, is it low, and you need to determine what is the cause lah, whether it's respiratory or metabolic. And then you look at the other end, the other one that is not causing it. So if it's respiratory acidosis, so you see for metabolic compensation, so the bicarb is increased in respiratory acidosis. In short, the answer is yes. I will just look at the pH as a big guide to whether these are compensated. But to be more accurate, definitely you should use your Winter's formula or not to calculate.
All right. Thank you so much, Doctor.
Yeah.
Any further questions? We will close in 1 minute if there are no further questions.
Okay, before we close, I would like to say thank you to Benjet and the organizing team. I think this is a very commendable effort. We never used to have this during my days as a medical student, and I think this is a great effort by Medical Society. I'm very proud of you for doing this, and I understand that you've been doing it with many other clinicians as well, including your surgeons, your obstetricians as well. And I think it's a great way for you guys to learn even at your own time and your own pace, even though you may not even be in your clinical years, but this will give you a perspective on how we see and manage patients, and will help you to understand the disease and management better as well.
Okay, thank you, Dr. Lim, for being our guest speaker for this session. The whole case was a bit complicated for preclinical students, I would admit, but for the clinical students, I hope they have benefited from it. And if there are house officers or even medical officers here as well. Once again, I'd like to extend our greatest appreciation for Dr. Lim for being our guest speaker. And thank you for all the participants for joining us on Friday night. If there are no questions left, we'll close this session now.
All right. Thank you, everyone.
Thank you, Doctor.
Thank you for the session, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
All right.
Thank you, Doctor.
Okay.